Okay, guys, we're ready to begin Chapter 8, Joints of the Skeletal System. So let me share my screen so we can go to the PowerPoint, which of course you have access to in Blackboard. So when we talk about joints, another term we could use to describe this is the word articulation. And so where two bones come together, of course, we have a joint or an articulation. So one function is the role they play and obviously connecting bone to bone at that particular joint site. As we've talked about recently in the skeletal system, in a very odd kind of way, that epiphyseal growth plate, where of course lengthening of long bone occurs, is a joint, as we'll talk about a little bit later. So the ability of bone to grow in terms of endochondral ossification, that process, is another function really of that specific type of joint that we, again, will talk about in just a moment. During the process of childbirth, as the baby passes through the birth canal, there have to be changes that occur to the skeleton of the female to allow that birthing process, that labor that results in the birth of the baby. And then, of course, when we talk about skeletal muscle, which you know is voluntary, the movement of the body occurring as a result of contraction of that muscle, pulling and pushing on bones at joints, is another major function, of course, of an articulation. So one approach to describe the functionality, if you will, of a joint can probably be best thought of as to what degree is there movement at that joint. Most of us, when we think of joints, think of, the joint, the knee joint, the hip joint, the shoulder joint. Those are called diarthrotic joints. And so we're going to introduce some terms now that describe degree of movement. Diarthrotic, for example, as I mentioned a moment ago, is a freely movable joint, which again is the one that we're most familiar with. But there are other degrees of movement as well besides freely movable. And here's the first one. A synarthrotic joint refers to an immovable joint. And I'll give you some examples of these in just a few moments. But again, we're just looking at the degree of movement from a sort of a functional standpoint. Amphiarthrotic, defined as slightly movable. And then the third one that I mentioned a few moments ago, like our hip joint, our ankle, our knee, shoulder, those are diarthrotic joints or freely movable joints. So I'd like you to know these terms, be familiar with what they refer to, because we will be using these functional terms as we begin to approach and look at the different structural types of joints, which is really the approach that most textbooks use. Your lab manual as well generally defines joints based on structure. What sort of tissue is binding those bones together at that articulation? Okay, so we're going to adopt primarily this anatomic or structural classification. Even though we understand, of course, that structure and function do have a lot of overlapping with one another. And you'll begin to see that in just a minute. So let's, again, talk a little bit about the different types of joints based on what tissue holds these bones together. There are three structural classification schemes. This is the first, of course, called the fibrous joint. And note that the type of connective tissue that binds or connects bones within fibrous joints is dense regular connective tissue. Now, if you don't remember what that is, you should go back into chapter 5 on tissues and check out page 165 where they talk about dense regular connective tissue. We've talked about this a lot already. Remember the densely packed thick collagen fibers, right? That's the primary type of fiber found here in this type of connective tissue. And we gave the example of ligaments and tendons, right? Remember that? Okay. So this is the same kind of tissue, same kind of connective tissue that's binding bones at this fibrous joint. And typically, as it mentions here, the bones are in very close contact with one another. And I'll give you some examples of fibrous joints in just a moment, but let me just go over the 3 types of structural joints. Number 2, cartilaginous. I think that speaks for itself. It's cartilage that holds these bones together. Now, again, I hope you remember the 3 types of cartilage. You should know these. What are they? You see 2 listed, right? Hyaline and fibrocartilage. What's the 3rd type? Elastic, right? Well, elastic cartilage does not play a role in the formation of cartilaginous joints. It's just hyaline or fibrocartilage. Okay, and again, I'll give you examples in just a minute. And finally, the one that you and I are most familiar with in terms of functionality, maybe you've never heard the term synovial before, but we'll be talking about what makes a synovial joint different from a cartilaginous or a fibrous joint in just a moment. But most of our joints in our body, those diarthrotic, freely movable joints, are synovial joints. Okay, let's get into the 3 structural examples, types, and give you some specific places in the body to go to find these. So within the fibrous category, remember, dense fibrous connective tissue binding these bones, we have 3 types of fibrous joints: a syndesmosis joint, a suture, and a gomphosis. You're already familiar with the second one there, suture. These other 2, probably not so much. So let's give some examples, starting with the syndesmosis fibrous joint. And it's telling us to go to the distal ends of the tibia and the fibula. We just finished up the appendicular skeleton last week in class. So again, you should be super familiar with where I'm talking. So we're down here at the ankle. And when you look at the tibia and the fibula, the distal ends of those bones, you will find actually 2 syndesmosis fibrous joints shown here in red, the red lettering. We have here between the diaphyses of these 2 bones something called the interosseous ligament. This is that dense fibrous connective tissue, sort of a band of it here between the fibula and the tibia. And then way down where the lateral malleolus of the fibula articulates here with the lateral region of the tibia is something called the interosseous ligament. Now we know it's a ligament, but because it connects bone to bone, so that shouldn't surprise us, right? For whatever reason, they call this a membrane, they call this a ligament. You know, histologically, they're the same connective tissue. But here's an example of where you find a syndesmosis fibrous joint. From a functionality point of view, this is considered amphiarthrotic because it does provide some movability. A suture, which you learned about a couple weeks ago in lab, has found between the flat bones of the skull, is also a type of joint bound by fibrous connective tissue. So if you were to look in you or me, not in so much the skeleton, because this sutural ligament has been dissolved when they went to prepare the skull for use in the laboratory or in the classroom. But if you can look into your sutures, right in the very center of the suture, you'd find a very thin layer of dense connective tissue between sort of the margins here of the sutures. And that's what holds those bones together. Of course, the bony margin here of the suture also, of course, helps to bind, but the connective tissue is also there to help hold those flat bones together at the suture. Notice that this is a synarthrotic or immovable joint, which we all kind of know. Now, this is not the case in the infant. As the birthing process occurs, as we talked about in class, there we don't have full suture formation yet because the skull has to be able to conform to the birth canal as the head passes through. So the formation of this suture occurs for the most part after birth. Full formation of sutures don't take place until after birth. And our last example of a fibrous joint, the gomphosis, where a bony process fits into a socket. And they use the metaphor of pounding a nail into wood. So a coney portion, a bony, cone-shaped bony process fitting into bone. And they're telling us to look at teeth. And of course, you see here a diagram of what looks to be a canine tooth. And where the tooth embeds itself within the maxilla or the mandible, and you can see the spongy bone here and compact bone of the mandible or maxilla, but between the bone and the tooth is a fibrous connective tissue we call the periodontal ligament. Now again, typically we think of ligaments as connecting bone to bone. A tooth is not really bone, but nonetheless, we use that term ligament because it is like the nail pounded into the wood, only here we're kind of pounding the nail into the bone, if you will. Let's think of that metaphor. And that periodontal ligament is what anchors the tooth in the maxilla or the mandible. Let's hope it's synarthrotic, right? Yeah. Now, if a person suffers from periodontitis, which is an inflammation of the periodontal ligament, this can eventually become diseased. This ligament can become diseased and be replaced by other types of abnormal tissue, and that can result in the cutting off of the blood supply to the tooth. Now, you probably don't understand or realize that your teeth are not, dead. They're living structures, because in the core of any of your teeth are blood vessels, as we can see here in the diagram. If you cut off blood supply to the tooth, it turns gray or black, and it's dead. So we don't often see this in today's society, but prior to modern dentistry and health insurance, it was not uncommon to see people with black or gray teeth. Their teeth died as a result of maybe poor hygiene. They didn't brush their teeth, and they ended up with periodontitis, perhaps, and the blood supply to the tooth was cut off and the tooth died. Okay, let's move on to cartilaginous joints. Two major types as listed here: synchondrosis and symphysis. This might sound familiar to you because we talked about the symphysis pubis recently in lab. Does anybody remember where that is? Symphysis pubis. Well, we'll see if you remember. We're going to review that in just a moment. Let's talk about a synchondrosis type of cartilaginous joint. So now we're focused on cartilage binding the bones together. And as we just recently talked about in chapter 7 on the skeletal system, here we see a diagram of what appears to be a future femur, right? Certainly looks like a femur. In an adolescent, let's say. Why do I say that? Because I still have intact cartilaginous epiphyseal growth plates, shown here in white, as the arrows indicate. And again, if you think back to the previous chapter, this is hyaline cartilage binding the bone, parts of the bone together. They're not two bones, they're within the same bone, obviously, but we can see here the primary ossification center, moving north, if you will, and south, and then we have the secondary centers growing here in the epiphyses, and between the two is our intact hyaline cartilage making up the epiphyseal growth plate. So it is technically a joint, it's binding bones together, and let's hope it's synarthrotic, right? Immovable, which it is. Okay, here's another example of a synchondrosis cartilaginous joint. It's telling us to look here where the first pair of ribs articulates with the manubrium of the sternum. Again, we talked about all of these bones in lab. So this should not be new to you. So here, between, again, the first pair of ribs and the sternum, in white is hyaline cartilage. In fact, all of this is hyaline cartilage, right? It's costal cartilage, costal referring to ribs. But I'm looking here specifically at the first pair of ribs and where it articulates with the sternum, because this is a special type of cartilaginous joint, a synchondrosis joint, because this is a synarthrotic joint. Immovable. There's no movement between the first pair of ribs and the manubrium. And you might be thinking, well, what makes that different from all the other ribbed pairs, and where they articulate with the sternum? Shouldn't be much different. Well, interestingly enough, when you look at the remaining pairs of ribs, these are not synchondrosis joints. They are technically synovial joints. And we'll be talking about that in just a few moments. So clear distinction between the first pair of ribs and pairs 2 through 10. They are a different type of joint. This is a cartilaginous synchondrosis, the first pair, and the remaining pairs are synovial joints. And our second type of cartilaginous joint, the symphysis, unlike the synchondrosis type of joint, here we have fibrocartilage binding the bones or found between the bones. And here's the pubic symphysis or symphysis pubis, same thing, between the two pubic bones of the hip, or of the coxal bone, excuse me, the pelvis. We have that piece of fibrocartilage, right? We've talked about this before. Note, this is amphiarthrotic because, as I said earlier, in terms of the function slide, there has to be give or movement of this joint during the birthing process. So this is amphiarthrotic. But again, fibrocartilage. Another place that we talked about going to find fibrocartilage in the body is between the vertebrae, right? The intervertebral discs. This likewise is amphiarthrotic, slightly movable. And it appears as if this is showing a cutaway view of some thoracic vertebrae, I would think. Look at the downward pointing spinous processes. Amphiarthrotic. Okay, and finally on to structural type number 3, our last kind, synovial. These are freely movable. These, remember, again, are the ones that you and I are most familiar with. And as we talk about these diarthrotic synovial joints, we're going to be coming up with terms that we can use to describe the structural framework of almost any synovial joint. So I'm going to be giving you some terms now in a diagram we can look at to define some of these important structures. So let's pretend we have two bones. If you want to think of this as the femur and this is the tibia, you could do that. If you want to think of this as the humerus and this as the ulna, you can do that. If you want to think of this as the proximal phalange of your index finger and the middle phalange, you can do that. So we can go almost anywhere within a synovial joint and talk about some of these structures. The first of which simply reviews the fact that on the epiphyses, and the epiphyseal ends of these two bones, we have a thin layer of articular cartilage, which you know is which of the three types? Hyaline, right. And so a couple millimeters thick would be sort of the maximum thickness of this articular cartilage. Now, if we're talking again about phalanges, it might be 1 millimeter thick. It just depends upon the size of the joint. But if we're looking at femur tibia, it's going to be several millimeters in thickness. Now remember, this is the only part of a long bone where we have cartilage, because the remaining part of long bones, in terms of the diaphyses and metaphysis, would be covered by periosteum. On the very outer surface is something called the joint capsule. So this is sort of shown in gray here. And oftentimes, the very outer portion of the joint capsule is dense connective tissue. Okay, it's often a ligament or a series of ligaments that help to bind these bones together externally. And this dense connective tissue basically connects to the periosteum regions of these bones. On the very inner surface of the joint capsule is something called the synovial membrane, and that's where the term synovial joint comes from. This very, very, very thin membrane that lines the innermost surface here of the joint capsule. So what I'm showing you here as a dark blue region, this would be synovial membrane. And inside would be a synovial cavity or joint cavity filled with synovial fluid. Okay, so the synovial fluid is produced by the synovial membrane and is a lubricant. And I often, define it as the 10W40 of the body. It's an oil-like material in terms of its lubrication function. It's actually a clear, somewhat snotty material if you were to actually see synovial fluid up close and personal. It'd be kind of thick, clear. And its purpose is kind of twofold. The primary purpose is, again, acting as a lubricant. And the other thing that it can do actually is supply nutrients to the articular cartilage as well. And note that in the knee joint, which is a fairly sizable synovial joint, we're talking about less than 0.5 milliliter of fluid. Now, to give you some idea of how much that is, that's about 10 drops. So it doesn't take much synovial fluid to function properly within a large joint, let's say like the knee. If we're talking about between the phalanges, it's even less than that. Once in a while, you can also find menisci between bones. And I don't have a diagram right here in front of me, but if you remember, or soon you will be hearing about the knee joint and looking at the model in lab, where we have two menisci here between the condyles of the femur and the tibia. There's a lateral meniscus and a medial meniscus. The term meniscus is singular, menisci is plural. And so in some synovial joints, like the knee, you may find these pieces of fibrocartilage. They're not super common in most synovial joints, but with regard to the knee, yes, that's where you can find it. We can also find structures called bursae. That again would be plural. A bursa would be one fluid-filled sac, and I'll give you some examples of bursae in just a few moments. But that fluid inside the sac, that's again synovial fluid. Here we have a sagittal cut through the knee joint. And again, to orient you, here's the femur, here's the tibia. The fibula is not shown. Here's our patella. So this is the anterior or front of the knee. Here's the back of the knee over here. And again, we can see the outer joint capsule in gray, made of dense fibrous connective tissue, really making up what you and I would refer to as tendons, right? Or ligaments, depending upon where we are. So we call this a tendon because we're connecting bone to a muscle. The quadriceps muscle lies up here. And then we're calling this a ligament because we're binding the patella to the tibia. But nonetheless, histologically, ligaments and tendons are both the same, right? Lots of collagen, collagenous fibers. And then we see here in dark blue, the synovial membrane, which remember produces the synovial fluid within this joint cavity or synovial cavity. So here's what the synovial fluid is, the 10 drops I was referring to a few moments ago. What you don't see here, well, you do see them. They do mention menisci, but I don't like how the way they drew this. This meniscus really should be extending further in to the center of the joint cavity and then back. And I think I would have drew this guy in a little bit more and pulled it back, because these condyles, right, of the femur and the tibia, they don't actually touch one another. So I think they should have definitely brought these in a little bit further to indicate that when there's movement of the knee, that those condyles are actually contacting the fibrocartilaginous menisci and not the articular cartilage of the ends of the bones. So I think, again, I think they could do that a better job in diagramming that. Here are some of those bursae I was referring to in the earlier slide, those closed sacs. So we've got here one called the prepatellar, meaning in front of the patella, so that's aptly named. Here's an infrapatellar bursa, and then we have a bit of an extension of the actual joint capsule here, forming what's called the suprapatellar bursa. So this is not so much a closed sac like these guys are, but is rather more of a continuation of the main joint capsule or cavity of the knee. Now, once in a while, you hear people getting bursitis. Now remember, itis, that suffix, itis, stands for inflammation of. We talked earlier about periodontitis, inflammation of the periodontal ligament in that gomphosis joint. Or we could talk about appendicitis, laryngitis, arthritis, right? Here we have bursitis, an inflammation of the bursae. And typically what occurs here is the synovial membrane that lines each bursa is producing too much synovial fluid, and there tends to be a bit of swelling, sometimes a lot of swelling, and discomfort associated with bursitis. And that is a bit of an age-related phenomenon. Some people claim, I'm not sure exactly if this is really true, that they can tell when there's a weather change approaching. It's going to get cold, it's going to rain, going to snow, whatever. They say, oh, my bursitis is acting up. Again, I don't know if there's much science behind those claims, but you often hear about that. This is a anterior view of the flexed knee. And again, this is the very same diagram that we have in the lab book in, I think, exercise 18 on joint movements and joint structure. So you will have seen this already, or you will see it very soon. What I do like about this is it shows the lateral and medial meniscus very nicely. You can get a sense again of the fact that the condyles here of the femur, as well as the condyles of the tibia, do not have direct contact, but rather this very important, strong connective tissue helping to allow for, in concert with the synovial fluid, a friction-free movement of the joint as one extends and flexes the knee. We can also see a bit of the lateral collateral ligament here and medial collateral ligament, which acts to reinforce and strengthen the lateral and medial surfaces here, of course, of the knee. And then another thing I think worth mentioning are the cruciate ligaments. Here we have what's called the anterior cruciate, and of course behind it the posterior cruciate. They're called cruciate because they kind of cross one another, making an X-shaped, shape as you look at their morphologies. So this is providing internal central reinforcement of the knee joint, as opposed to the lateral and medial menisci, or I'm sorry, lateral and medial ligaments providing external reinforcement of the knee joint. Here's a sagittal view through a cadaver knee, and again you can see the femur, the condyles of the femur. Here's the tibia, here's the fibula. Here's the articular cartilage in light yellow. Notice again it's about 1 millimeter or 2 thick. Here's the anterior cruciate ligament. You can see it. The posterior is kind of obscured. One thing that they do show a little bit here is the lateral meniscus. There should be a medial meniscus over here. It's not shown very well. Just could be due to the fact of where the sagittal cut was made, I suspect. But this again extends inward, as you can kind of see here, to cushion the condyles. We don't want to have contact between the two, which you would get that impression if you look at this, right? But in reality, that lateral meniscus and medial meniscus is going to prevent that condyle-to-condyle contact. This just talks a little bit about the external part of the synovial joint, the joint capsule, and we can see again that we've got some muscle here in red. The white is depicting the dense connective tissue. Most of these are ligaments because they're binding bone to bone. You don't need to know the names of these, but I've outlined them in green just to kind of give you an idea of the extensive networking of ligaments. Here's our lateral and medial collateral ligaments that you saw in one of the earlier diagrams, but there are additional ligaments that are further supporting and reinforcing the external part of the joint capsule. So that knee joint is a very complex joint, isn't it? You can just kind of get a sense of that as you look at the orientation of many of these ligaments helping to reinforce that knee. This is a really excellent video. You just click on this little play button and this will take you through and review the 3 structural types of joints, right? You remember those are fibrous, cartilaginous, and synovial joints. They also talk about osteo and rheumatoid arthritis. And there is a clinical application box in your book on page 286, 287 that talks about bursitis, rheumatoid, and osteoarthritis, which the video, of course, does too. So I would like you to watch that video. I'd like you to look at that clinical application box. Very interesting stuff. And I think that will conclude the first module. In the next module, we'll talk about the different types of synovial joints, and we'll talk about joint movements.